Our third speaker is Dr. Rasanga Lakmal Gunawardana, consultant orthopedic surgeon and senior lecturer in the Department of Surgery at the Faculty of Medicine, University of Ruhuna, Sri Lanka. He will talk about knee arthroplasty for knee osteoarthritis. Dr. Gunawardana had received his medical degree from the Faculty of Medicine, University of Colombo. He had received his Doctor of Medicine in Orthopaedic Surgery from the Postgraduate Institute of Medicine, Colombo, Sri Lanka, and is currently a member of the Royal College of Surgeons, England. I warmly welcome Dr. Rasanga Lakmal Gunawardana, consultant orthopedic surgeon and senior lecturer.
Good evening, everyone. Can you all hear me?
Yes, sir.
All right.
Of course.
Yes,
All
sir.
right. So, first of all, I would like to congratulate Sri Lanka Society of Physiotherapy for organizing this international webinar, and I hope it would be a great success. And thank you very much for the organizing committee for inviting me, especially Mr. Kumar Senanayaka, personally invite me for this event. And can you all see my screen?
Sir, you can see, sir.
Yes, sir.
Yes,
Of course.
Yeah, you can see. All right. So today we are going to discuss about knee arthroplasty for knee osteoarthritis with important concept which will be beneficial for all our physiotherapy colleagues. So first of all, we'll see what is the indication for the objectives of this lecture. So first one is indication for arthroplasty, and I'll touch about non-arthroplasty surgical option to make this lecture complete, and we talk about types of knee arthroplasty and a bit about the history or the evolution of knee arthroplasty, the concepts in prosthesis design, surgical approaches, some recent advances in knee arthroplasty, and finally the complications of knee arthroplasty. So hope most of the topics will be beneficial for all of you, the participants. So what are the indications for arthroplasty? First of all, our main aim is to relieve pain caused by severe knee arthritis, especially following osteoarthritis or inflammatory arthritis, and cartilage space loss confirmed on radiograph, severe pain from even gout, pseudogout, or chondrocalcinosis, and severe progressive deformity. And finally, the exhaustion of non-surgical treatment, which we all know we give for osteoarthritis, the non-steroidal anti-inflammatory drugs, injections, activity modifications, and physical therapy, and etc. So once these are exhausted, the only option available is for knee arthroplasty. So what are the contraindications for knee arthroplasty? So one is active ongoing infection. Second one is incompetent extensor mechanism and compromised vascularity in the lower limb, recoatum deformity secondary to muscular weakness, any local neurological disruption affecting the muscles around the knee, and presence of a painless, well-functioning arthrodesis, and any medical conditions precluding participation in a rehabilitation program, or the patient who is not fit for anesthesia. So there are some non-arthroplasty surgical treatments which are offered for knee osteoarthritis. I'm not going to go into details on these things, but for the completeness, I will mention it here. There are arthroscopic management of arthritic knees, osteotomies like high tibial osteotomy, and cartilage reparative and restorative procedures, and all the non-technique knee arthrodesis. All right. So when you talk about arthroplasty, there are few variations in arthroplasty. So one is total knee arthroplasty. We all know we replace all articular surface, the femoral condylar and the tibia and the patella articular surface. So that is the total knee arthroplasty or the total condylar arthroplasty. And then there will be unicompartmental knee arthroplasty, where we replace only the affected compartment, mainly medial, but sometimes laterally, and isolated patellofemoral arthroplasty. So what is the success of total knee or total condylar arthroplasty in literature? So the survival rate for total condylar or total knee prosthesis range from about 91 to 96% for about 14 to 15 year follow-up. And the rates will differ with different types of prosthesis. For posterior cruciate ligament remaining type of knee arthroplasty, it's about 96 to 97 at 10 to 12 year follow-up. And for the PCL substituting type, 97 at 10 years and 94 at 13 years. And survival rate for cementless range for about 95 to 97 at 10 to 12 years. So we all know these have proven result for good results for total knee arthroplasty. Then unicompartmental arthroplasty. We do this operation for certain identified specific indications. The criteria are mainly for non-inflammatory arthritis, purely osteoarthritis, less than 10 degrees of varus or less than 5 degrees of varus deformities, and intact anterior cruciate ligament, and the patient should have at least 90 degrees of flexion and without any evidence of medial lateral subluxation. There shouldn't be any FFD or flexion deformity, should be less than 15 degrees, and all the deformities should be correctable. And there should be no collapse in the opposite compartment in the X-ray. And the patellofemoral OA also should be less than grade 3. And the main thing is the patient has to be less than 90 kilograms in weight. Okay, so this procedure offers advantage for two specific groups of patients. One population is the middle age or with younger patients, which we did osteotomy initially, but now we have the option as a unicompartmental arthroplasty. The advantage in this procedure in this group is they have a higher initial success rate and few complications with more acceptable cosmetic appearance and long-lasting results. And we can easily convert into a total knee arthroplasty if the other compartments degenerates. And octogenarians, or the people who are old enough, who are not expected to outlive the implant life. So these people are very old people. This will give a faster recovery with less blood loss and less medical morbidity following surgery, and the expense also less. And if you take the results of unicompartmental arthroplasty, the first decade results are good. The 10-year survival rates range from 87.4 to 96. And the standard failure rates in the first decade is less than 1% per year. So second decade results, there's a rapid decline in survivorship is noted. The 15-year survival rates range from goes down to 79 to 90%. Okay, so the patellofemoral arthroplasty, or the isolated patellofemoral replacement, indicated for isolated patellofemoral osteoarthritis, post-traumatic arthrosis, severe chondrosis outbreach grade 4, and failed non-surgical treatments. And patients who are symptomatic during prolonged sitting, stairs or hill ambulation or squatting will get benefited. The results are like this. It's about 85% good to excellent results are there. The failures are usually associated with uncorrected alignments and progression of the tibiofemoral arthritis. And the higher failure rates are reported in some poor functional outcomes, which are correlated to the implant designs. And the cemented versions are with good outcome. So, evolution of arthroplasty. How has this evolved into the current total knee arthroplasty? So, in 19th century, they were tried interposition of soft tissues for reconstruction of the damaged articular surface. They have used a lot of ingredient products and tried. And by about 1950s, the Waldis designed the first hinge knee replacement. And by 1958, they have introduced acrylic tibial plateau processes, mainly to correct deformities in the knee joint. So these are some of the pictures which I could get it from web. And by around 1960s, the first cemented surface arthroplasty of knee joint was introduced. And there were improvement of the Valdez hinge by 1970. And by about 1973, the total condylar prosthesis is introduced, which is first to resurface all three compartments. At it was a PCL sacrificing arthroplasty. So this is how it has evolved up to the current arthroplasty practices. Okay, there are several concepts and processes which will be important for a physiotherapist also, because we all want to get a better near normal knee kinematics after surgery. So the concepts are evolving quickly, but there are things which are important to mention here. So one thing is the femoral rollback phenomenon, the constraint of the implant, the modularity, and the fixation. And mainly the designs. What are the designs available now in the market? So femoral rollback, by definition, is a posterior translation of femur with progressive flexion. So the importance of this is it improves the quadriceps function, and mainly the range of knee flexion will be improved by preventing the posterior impingement of the distal femur during deflection. So this is very important in this Asian culture, where the patients tend to go for deep flexion for their cultural practices. So this is very important to get the deep flexion. So biomechanics will be normally in a native knee. It was done controlled by the ACL and PCL, and designs, both PCL retaining and PCL substituting designs, allow for some sort of a femoral rollback to allow full flexion. So constraint by definition is the ability to prosthesis to provide the varus valgus or flexion extension stability, especially in the face of ligament laxity or bone loss. We all know we get to operate on patients who have different degrees of ligament laxity or damage or bone loss because of the delay in presentation sometimes. So important is, if there's a ligament laxity or severe bone loss, the standard cruciate retaining or posterior stabilized implant might not provide enough stability, especially varus valgus. So the design has gone from cruciate retaining, posterior stabilized design to varus valgus constrained non-hinge design, and for the more constrained rotating hinge type arthroplasty to get this varus valgus and flexion extension stability. So modularity, again a definition where the ability to augment a normal processes when there's a soft tissue or bone loss, and the options include metal base plate with modular polythene inserts and modular femoral and tibial stems with extension. An advantage is we can customize the implant intraoperatively depending on the bone loss or the deformity. But the disadvantage is there's an increased risk of osteolosis in modular compartments and backside polythene wear. So the fixation, most of the time it's cemented. There's a proven survivorship and function due to high viscosity cement, which has a long working time. And sometimes they are antibiotic impregnated. And cementless, the trabecular surface allow for long-term biological fixation with trabecular metal. So the designs are, we divide the total knee arthroplasty designs into unconstrained, posterior cruciate retaining, or posterior cruciate substituting, and constrained types are non-hinge and hinge knee arthroplasty. And there's fixed versus mobile bearing also. I'll just touch on this concept. The posterior cruciate retaining is where the design, it's a minimally constrained processes that the function is dependent on an intact posterior cruciate ligament, provides stability in flexion. We don't remove the posterior cruciate ligament in this type of processes. So this is how it appears in the X-ray. And it won't show the box in the central portion of the femoral component as in a posterior stabilized. You will see the next X-ray in the next slide. So the advantage, the indications are the arthritis with minimal bone loss and minimal soft tissue laxity and an intact PCL for the posterior cruciate retaining implants, and the varus deformity less than 10 degrees and a valgus deformity less than 15 degrees. Advantages, it's avoid the tibial post-cam impingement or dislocation which can happen in a posterior stabilized knee, which I will explain later, and most closely resemble normal knee kinematics. It's also a controversial topic, but the less distal femur cuts need in PS than the posterior stabilized knees, and the improved proprioception because of the preservation of the native PCL. There are disadvantages also. A tight PCL will cause accelerated wear, and loose or ruptured PCL lead to flexion instability after the surgery. Then the next option is for the posterior cruciate substituting type, where we will cut the posterior cruciate ligament during the surgery. So it's more constrained, but requires a sacrifice of posterior cruciate ligament, and it will increase the flexion gap when you resect the PCL, and it has to be meshed to avoid any mismatch in the flexion and extension during the knee movement. And femoral component has a cam that a box that engage the tibial polyethylene post that will give the function of PCL, and they are more congruent and deeply dished and more stable. So when you take the lateral radiograph, it will show, as the arrow shows, outline of the cam or the box in the femoral component where the polyethylene stem going. So the indicated, especially with people with previous patellectomy, and it has reduced the potential anterior posterior stability, especially in the people of with weak extensor mechanism, and inflammatory arthritis. When there's a late PCL rupture, this type of implant is indicated, and especially people who don't have PCL or absent PCL. Advantages: it's easy to do balance the knee with absent PCL and more range of movement and early surgical exposure because we remove all the soft tissues. And at disadvantages, this cam jump mechanism where with loose flexion, the cam can rotate over the post and dislocate, and tibial post can go into wear. And there's another phenomenon called patella-trunk syndrome, which I will discuss later with the complications. Then more constrained one is a non-hinge design, and it without the axial connection, without a hinge, but it is more constrained. And the large tibial post and deep femoral box will give more stability. Indicated especially for ACL, MCL deficiency, and if there's a flexion gap laxity, and sometimes in moderate bone loss in the setting of neuropathic arthropathy. So the radiograph will show this special implant with more longer stems in the femoral and tibial canal and more deep dish, which cannot be seen in the X-ray. But we can see in the implant picture the deep dish and the tibial post will give the stability, which is more than in a posterior stabilized knee. So then the advantages: it allows stability in the soft tissue or bone deficiency. Disadvantages: we have to resect more femur bone and to accommodate the large box, and there's a risk of aseptic loosening due to the increased constraint. Then the constraint hinge, the ultimate constraint implant, is the most constrained, and there's a link in between the femoral tibial component like a hinge. So it can rotate around a yoke in the tibial platform, and it will give us good constraint. And indicated in global ligamentous deficiencies, there are people with all ligament deficiency where we cannot do a standard total knee replacement. Then this would be the ideal implant. And especially with hyperextensive instability seen in polio or tumor resections, when you remove a lot of soft tissues and bone, we cannot get the stability from the ligament. So we have to rely on a constrained hinge design, and especially in a massive bone loss setting. And you can see the radiograph where the femur, there's a massive bone resection, and it is replaced by the hinge knee replacement with modularity allow the implant to get the correct length of the limb. So this is a constrained hinge type of a design. When you see the X-ray, you can see. So allow stability, and the disadvantage again is the aseptic loosening as a result of increased constraint. And sometimes you need to remove large amount of bone. So mobile bearing again is a concept where you will allow young inactive patients to rotate the tibial, the polyethylene insert over the tibial base plate. So advantage is reduced polyethylene wear due to increased contactless area. Disadvantage is it can spin out because there's a no tight fix. And you can see here the polyethylene insert can rotate on the tibial base plate. It will give more movement theoretically. So up to now we have discussed about the evolution and indications and the concept in general or knee arthroplasty. Now I will touch on the surgical approach, which will be important, especially in rehabilitation with the physiotherapy point of view, depending on how we cut the muscles, the rehabilitation protocols may change. So I will touch on the some of the surgical approaches which are used for total knee replacement, and understanding that will help for a better rehabilitation with physical therapy. So the surgical approach is mainly Can you all hear me?
Yes, sir. We can hear you, sir.
Yeah, we can see the slides also. All right, thank you.
Yeah, sure, sir.
And yeah, okay. So the surgical approach is dictated by the surgeon's preference, the prior incisions, and degree of deformity and patella bhaja, and if the patient is obese. So when you talk about the approaches, there are simple or the primary knee arthroplasty approaches, which are the commonest medial parapatellar approach, the mid-vestus approach, sub-vestus approach, and lateral parapatellar approaches. And there are now minimally invasive surgical approaches. But when you go to complex procedures, they are done in some primary and mainly in revision total knee arthroplasty. So these are quadriceps snip, VY turn down, and tibial tubercle osteotomy, where we need a good approach in complex cases. So I'll touch on these standard approaches. So the standard medial parapatellar approach is the most commonly used approach. The skin incision will be a straight midline, and then we'll go for the medial parapatellar approach. So you can see the black line depicts the line of incision over the approach. Okay, so the advantage over here is familiar with most orthopedic surgeons, and it will give external exposure because we can get the patella everting very easily, and even in challenging cases. The disadvantage is there's a possible failure of medial capsular repair, and development of lateral patellar subluxation due to that. The lateral reticulum access is less direct with this medial approach, and it can harm the patellar circulation if there will be both lateral and medial release. So the mid-vestus approach is another approach where similar to the skin incision is similar to the medial parapatellar, but it spares the vestus medialis obliquus insertion and may lead to quicker recovery because the less cut into the extensor mechanism. I hope you can see the image, and the black line depicts the approach. So advantage is the insertion on vestus medialis, insertion on quadriceps is minimally disrupted and allowed accelerated rehabilitation due to the extensor mechanism is not disrupted, and patellar tracking may be improved because of compared with the medial parapatellar approach. Disadvantage are less extensile, and especially in obese patient with this limited approach, we might not be able to get a good exposure, and especially with flexion contractures, the exposure is difficult. So there's a small risk of partial denervation of VMO muscles. And contraindicated, especially if the range of movement is less than 80 degrees, and especially in obese patients. And hypertrophic arthritis, where there are a lot of osteophytes, we have to approach and remove, and previous high tibial osteotomy. Then there's a subvestus approach. So the muscle belly of vestus medialis is lifted from intramuscular septum without damaging the muscles. So it is a very less extensile approach. So the patellar vasculature is preserved, and the extensor mechanism remain intact throughout, and minimal need for lateral reticular release. And disadvantage are less extensile, and relative contraindications are especially in the revision TKR, and when if the patient has large quadriceps, we won't be able to have a good exposure with this method, and again with previous operations like high tibial osteotomy. And obese patients, it's very difficult to get a good exposure. And previous parapatellar arthrotomy is also a contraindication. So the lateral parapatellar approach is we use it limitedly only for difficult because it has difficulty in inverting the patella, and it is on the lateral side. The advantage is that is done for fixed valgus deformity, especially the people who are coming in rheumatoid arthritis who have a valgus type of deformity where we cannot correct it with the medial approach. But the good advantage is preserve the blood supply for patella, and the lateral patellar subluxation is prevented and give a good access for the lateral side to clear the tissues. Disadvantages are technically demanding because it is difficult to invert the patella, and the medial eversion of the patella is difficult, and sometimes might end up with tubercle osteotomy. And there are minimal invasive surgical approach in view of getting less scar, but they often need special instrument for exposure and implant insertion, and technically demanding because the exposure is very less. And outcomes, short-term data supports more rapid recovery because the muscle cut and the skin cut and the soft tissue handling is minimal, but long-term data need to compare outcomes and with the traditional exposures. The problem with this, when you go with minimal invasive, there's a high chance of the implants go into malposition due to minimal exposure. All right, so those are the standard approaches, and then we have this extensile exposures, which are important because there we are going to disrupt the quadriceps mechanism. The rehabilitation will be not easy as in a simple exposure. So one is the quadriceps snip. The technique is we made a snip at the apex of quadriceps tendon obliquely across the tendon at 45 degrees angle to the vastus lateralis. So the advantage of this procedure is there's no much change in the post-operative protocol. Minimal if there's any long-term consequence. Disadvantage is it is not very extensile as the tibial tubercle osteotomy. So the next one is the VY turn down, where we had a straight medial parapatellar arthrotomy and a diverging incision along the down the vastus lateralis towards the lateral retinaculum. So there we have the advantage of allow excellent exposure to the knee joint, and we can because this VY procedure can use for lengthening of the quadriceps tendon if there's any contracture, and it will preserve the patellar tendon and the tibial tubercle when comparing with the tubercle osteotomy. But there are disadvantages. The extensile leg will be there, and it will affect the quadriceps strength, and the knee need to be immobilized post-operatively, regain the continuity of the quadriceps tendon. So we might not be able to go for the normal physiotherapy protocols following these turn down procedures. The next one is tibial tubercle osteotomy, the ultimate exposure, where we take about 6 to 10 centimeter bone fragment from the tuberosity, and then later fix with screws or wires. The advantage is the exposure is excellent. We can see, visualize everything, and it will not have any problem in the quadriceps tendon, and it will avoid the quadriceps weakness. But the disadvantages are we have to immobilize the patient or limit weight bearing till the osteotomy site heals, and there can be avulsion fracture later, and there can be non-union of the osteotomy and wound healing problems also. Okay, now this concept of bilateral knee arthroplasty is worldwide practiced. When we have bilateral osteoarthritis, we will go for this bilateral total knee arthroplasty. So most of them do simultaneously. So sometimes 2 surgeons or even 1 surgeon performing 2 surgeons performing bilateral TKA at the same time with the given same anesthesia, and sequential is the ones single surgeon performing one TK and then go to the other side under one anesthetic. So that is sequential. And stage 1, so surgeon doing TK under separate anesthetic with a range of 3 days to 1 year in between each side. So people with bilateral total knee arthroplasty can undergo bilateral total knee arthroplasty in these methods. All right, so I will not go into the bone cuts and every thing in the surgery. Now, another important management is the pain management, which is help the patient to recover soon and help the patient to go into physiotherapy protocol soon. When there's pain, it's very difficult to follow up a proper physiotherapy management. So it's a very important part of knee arthroplasty is the pain management, because it's a very painful procedure with the bone cuts and things. So patient will have significant pain, but if you manage pain properly, the post-operative protocol will be adhered correctly and patient will be mobilized soon. So we start with pre-operatively. We can give non-steroidal anti-inflammatory drugs and opioids, immediate procedure before the procedure, preemptive analgesia, and intraoperative, the regional anesthesia, spinal or epidural are preferred, and peripheral nerve blocks give more coverage or to decrease the post-operative pain. And multimodal drug injections, periarticular, some surgeons practice. There are evidence for and against it, and it will decrease the post-operative pain. Then mainly post-operative, it's a multimodal oral drug therapy plus IV or subcutaneous treatments, starting with NSAIDs, which inhibit inflammatory media, and opioid, which act against mu receptors, and gabapentin, pregabalin also used for reduced hyperexcitability of neurons, and serotonin and noradrenergic reuptake inhibitors. So physical therapy, I will not go into detail. My colleagues will discuss it in the coming lectures. But usually it has to be we can start on the day of the surgery or so that it will reduce the length of hospital stay, reduce pain and improve function, and the range of movement requirement are for the gait swing pace, at least we need 65 degrees of flexion. And for activities of daily living, we have to get about 90 degrees of flexion. For the stairs, about 95 degrees of flexion in the knee. And for rise from chair, we need around 105 degrees of flexion. Those are the requirements. And discharge home criteria following total knee arthroplasty, mainly medically stable without any complications, acute complications, and around 80 to 90 active range of movements, and should be able to ambulate about 70 to 100 feet, and will be able to ascend or descend at least a flight of stairs. So I will touch on some new concepts in knee arthroplasty, which are patient-specific instrumentations, individual knee arthroplasty implants, sensors, accelerometer, robotic. I will go quickly just to get an idea what are the new things happening in the world of knee arthroplasty. So one concept is patient-specific instrumentations. We do 3D modeling, 3D imaging, and make implants according to the, especially the bone resection guides according to the patients, and they will be printed, 3D printed, and we send it to the operation theater, and it will use to get the personalized cutting guides to get cuts for these individual patients. So they will be like that. It will 3D printed according to the CT or MRI scans of the individual patients, and you will get the specific cuts for that individual. So it has advantages of getting specialized cuts. And there's this concept of individual knee arthroplasty implant. As you all know, we usually take over the counter, over the shelf implants according to the size which is available from each company. But individual arthroplasty, we make an individual implant with 3D modeling to the patients, and that is inserted following a personalized cutting blocks. So another new technology used in TK arthroplasty is sensors, where to get the optimum ligament balance, which if there's to limit the human error. So there will be sensors attached to get the correct soft tissue release and balance. And the monitor will show you the correct tension in the tissue. Then we can do the correct balancing with the improvement of the accuracy. And accelerometer also again sensor used to check the mobile one, check the alignment and the tissue tension in the bone. So it is use small sensors and capture it and see in a tab where we can align the femoral and tibial resection guide according to the data on the sensor, the monitor. All right, other thing is the robotic assisted knee arthroplasty, where you use what we do is have a 3D plan based on preoperative CT scans, and a robotic arm is helped to get the precise cut. So the human errors will be reduced, and it will get the precise cuts during the surgery, and it will improve the function of the joint, the replacement. All right, so I just went through some of the new concept in total knee arthroplasty, and there's another important concept. This is about the complication of total knee arthroplasty. As we all know, you are the people who are seeing the patient after surgery, and it's good to know what are the complications to be expected, and to refer the patients if you suspect if the patient is having leading to one of these complications. So it is always important for you all to know what are the complications following total knee arthroplasty. So there will be wound complication, prosthetic joint infections, vascular injury, peroneal nerve palsy, periprosthetic fractures, extensor mechanism ruptures, patellar maltracking, instability, aseptic loosening, patellar clunk syndrome, and joint stiffness, and heterotrophic ossification. So total knee arthroplasty is a very complex surgery. There are a lot of things involved, the processes, exposure of the bone, and a lot of tissue handling. So there can be a lot of complications associated with total knee arthroplasty, but it's always better to identify them and treat it, refer to the operated surgeon. Okay, so wound complications we see as a result of underlying systemic factor or direct trauma post-operatively. Diagnosis done with presence of incision breakdown or decision of the wound, and treatment depend on the size of the wound and the medical conditions. So the periprosthetic infection is very important to identify. It's a serious complication of knee arthroplasty, and it's a common cause for revision arthroplasty. In diagnosis is made by seeing the inflammatory markers and radiographic changes, and you need to give antibiotics or revision arthroplasty. And vascular injury and bleeding also can be there. So potentially devastating following TCAR due to the damage to the popliteal artery. So usually these acute complications which we identified soon after surgery. And there's a concept called the peroneal nerve palsy, which can happen due to damage of the peroneal nerve, especially with valgus knees with a flexion deformity. When you correct it, there can be stretching of the common peroneal nerve, and diagnosis is clinically made up with decreased sensation in the peroneal nerve distribution and weakness of the dorsiflexion. So most of the, I think when you are doing the physiotherapy, you might detect this weakness and always alert the clinician, because this has to be treated, especially just post-operatively. You have to put the knee in flexion to reduce the tension on the peroneal nerve, and sometimes in India, process orthosis to prevent foot drop, and we need to monitor the recovery of nerve. So that is an important complication. It's rare, but need to identify quickly and treat. And periprosthetic fracture can happen during any time. So it's a devastating complications, and you might see patient coming with pain and unable to move. So if you do the X-ray, you might have this complications. Distal femur, proximal tibia, or patella can be fractured. Diagnosis with X-rays, and treatment could be if it's undisplaced, non-operative, or displaced operative, depending on the location and the implant stability. So extensile mechanism rupture also can happen. This can happen during the rehabilitation process also. So it can rupture the patellar tendon or the quadriceps tendon. And the X-ray, in clinically, patient sudden onset unable to perform a straight leg raise should raise the suspicion, and X-ray will show the patella position alta or baja. The treatment depending on the available bone stock and chronicity of injury. And patellar maltracking, again a common problem, leading to patient dissatisfaction following total knee arthroplasty, and one of the common reason for secondary surgery. And it is again will be seen when you are rehabilitating the patient. Clinically, it combines with anterior knee pain, patellar subluxation during ambulation, and there's a limitation of knee flexion. So the treatment may be operative or non-operative. Instability, again, you can see a gross instability here. So it can be due to early failure following total knee arthroplasty. So it can be diagnosed, especially clinically, with the varus valgus thrust during ambulation and positive posterior sagging in the 90-degree posture. So sometimes we need to go for a more constrained arthroplasty if this happens. So that can be detected while the patient is being rehabilitated. You will see these complications. So aseptic dosing is a long-term complication due to macrophage-induced inflammatory response, non-infective due to bone loss and implant loosening. So long-term rehabilitation, you might get these patients with instability, and when you do the X-ray, you can see this aseptic loosening. And treatment most of the time end with revision. And patellar trunk syndrome, again an interesting complication, which you see a painful palpable trunk when you do the movement, and usually a palpable pop or catch as a knee extend at around 40 degrees of flexion. And when you do the arthroscopy, you can see this the fibrous nodule of scar tissues, especially in the posterior stabilized knees. And depending on the patient's symptoms, it can be observation or resection under arthroscopy. So joint stiffness, it's a common complication you all see following total knee replacement. So that is, we have to avoid things I have to avoid with proper rehabilitation. So the patient satisfaction and the functional outcome will be poor if the joint going into stiffness. So it's mainly diagnosed clinically, who have less than 90 degrees of flexion or a F50 of about 10 to 15 degrees. And treatment is, if you identify within 12 weeks, we can go for manipulation under anesthesia. But if it's more than 12 weeks, we have to go for adhesive disease, like arthroscopically or open, to get the flexion back. And heterotropic ossification, especially seen following surgery. Sometimes if you apply some Ayurvedic treatment, that will improve this, increase this presentation, where the bone formation in the soft tissues, which sometimes come with, can be diagnosed in the plain radiograph, and surgical excision is indicated only if there's a snapping or patellofemoral tracking difficulties. So reference would be these new technologies in arthroplasty and the AAOS comprehensive review and the orthopaedics.com. And thank you very much for giving me this opportunity and for the listening to my lecture. And I had to rush through because my time constraint and all. But if there's any question, feel free to ask me during this time.
So, can you hear me, please?
Yes, I can hear.
Yeah, once the total knee replacement is done, it's like a new bionic joint. And also this joint surfaces, the metallic joint surfaces, you get wear and tear, and you get like micro metallic particles, over when you do many exercises, or if you just allow the patient to walk or do anything, with a bionic joint, would it causes, later in life any problems with these particles remaining in the knee?
Yeah, it's can happen, but it's very rare in the knee. But this metal on metal processes we using for the hip replacement. Yes, there can be a lot of complications like LVAR and those due to these metal particles. But in the knee, there's a polyethylene insert always. We don't do metal on knee, so that complications are rare in knee. But yes, in hip replacement, there are metal on processes. There will be a lot of recognized complications.
Yeah, I have gone through, some articles about, like sarcoma, sarcomas and like that in the hip replacement.
Yes.
Not in knee replacement.
Knee is very rare because of the we always use the polyethylene. So the metal wear is less, but there will be polyethylene wear which can lead to this macrophages and lead into this non-infective loosening. Aseptic loosening can happen. Yes, that can happen.
Thank you so much.
Yes.
Thank you very much, sir. There is one more question, sir. Shall I read it, sir?
Yeah, please.
Are there less chance of getting venous complications after robotic TKR?
Actually, venous complication, the handling will be precise. So there will be less handling, so the less trauma on the venous system. But mainly venous complications are mainly due to the patient's conditions, whether the patient had a previous DVT or hypercoagular state. But robotics might lessen the complications because the handling is less and precise, not like in a total manual handling of the stretching of the veins.
Thank you very much, sir. Those are the questions, sir. Thank you very much. It's more informative.